You don't know me, but my name is Torma Ted. I was a Marine in Iwo Jima. I lost my best friend. There. The trauma caused the right side of my brain to ignite and overpower the left. I became a savant. Then I became a psychology major and PMHNP. I can't help my Marine instincts. I can't. They'll leave no man behind. I created this channel to share knowledge and create understanding. That way I can send my brainwaves out to help others. And not my soul.
What are anxiety disorders? Anxiety disorders are the most common class of mental disorders worldwide, affecting approximately 12.7% of the US population in any given year, with a lifetime prevalence of up to 34%. They are 1.3 to 2.4 times more prevalent in women than men, and the median age of onset is 11 years, meaning most anxiety disorders begin in childhood or adolescence. Despite being so common, up to 71 to 98% of patients with anxiety disorders are not correctly diagnosed, and approximately 41% receive no treatment at all. The key concept is that anxiety disorders involve fear, a reaction to an imminent threat, or anxiety, anticipation of a future threat, that is excessive, persistent, and causes clinically significant distress or functional impairment. Normal anxiety is adaptive and temporary. Pathological anxiety is disproportionate, uncontrollable, and disabling. The universal rule for all anxiety disorders: the symptoms must not be better explained by another mental disorder, a medical condition, hypothyroidism, cardiac arrhythmia, pheochromocytoma, or the effects of a substance/medication, caffeine, stimulants, alcohol withdrawal. Screening tools. Know your numbers. GAD-7, Generalized Anxiety Disorder 7, is the most widely used screening tool. It has 7 items scored 0 to 3 each. Total 0 to 21. Scoring: 0 to 4 equals minimal, 5 to 9 equals mild, 10 to 14 equals moderate, 15 to 21 equals severe. A score of greater than or equal to 10 has 79 to 89% sensitivity and 82 to 89% specificity for GAD. The GAD-7 can also be used as a general anxiety screener, though it is most specific for GAD and has fair, not excellent accuracy for panic disorder and social anxiety disorder. The GAD-2, first 2 items only, can be used as a rapid screen. A score of greater than or equal to 3 warrants completing the full GAD-7. Disorder-specific scales. The Leibowitz Social Anxiety Scale, LSAS, 24 items, range 0 to 144, is the gold standard for social anxiety disorder. A score greater than or equal to 30 indicates at least mild social anxiety. Sensitivity 94%, specificity 89%. The Panic Disorder Severity Scale. Self-report PDSSSR, 7 items, range 0 to 28, screens for panic disorder. A score greater than or equal to 9 suggests possible PD. The Social Phobia Inventory, SPIN, 17 items, uses a cutoff of greater than or equal to 19 for possible social anxiety. Always co-screen for depression. Anxiety and depression co-occur in up to 60% of cases. The PHQ-9 should be administered alongside any anxiety screening. The PHQ-4, GAD-2 plus PHQ-2 combined, is a 4-item ultra-rapid screen for both anxiety and depression. The Anxiety Disorder family, each one spelled out 1. Generalized Anxiety Disorder, GAD. The Chronic Worrier, DSM-5 criteria, all must be met. Criterion A: excessive anxiety and worry, apprehensive expectation about a number of events or activities, work, health, finances, family, minor matters, occurring more days than not for at least 6 months. Criterion B: the person finds it difficult to control the worry. Criterion C: the anxiety and worry are associated with greater than or equal to 3 of the following 6 symptoms, only 1 required in children. restlessness or feeling keyed up/on edge, being easily fatigued, difficulty concentrating or mind going blank, irritability, muscle tension, sleep disturbance, difficulty falling/staying asleep, or restless, unsatisfying sleep. Criterion D. The anxiety, worry, or physical symptoms cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. Criterion E. The disturbance is not attributable to the physiological effects of a substance or another medical condition. Criterion F. The disturbance is not better explained by another mental disorder. Memory trick. GAD's 6 symptoms. Wrist M. W. Wound up. Restlessness/on edge. R. Restless sleep, sleep disturbance. I. Irritability. S. Sore muscles, muscle tension. T. Tired easily, fatigue. M. Mind goes blank, concentration difficulty. Key differentiators. GAD worry is diffuse, spans multiple topics, and chronic, greater than or equal to 6 months. Unlike panic disorder, episodic surges, social anxiety, specific to social situations, or OCD, intrusive thoughts with compulsions, GAD is a constant background hum of worry about everyday life. Case example, Maria, 45, is a school principal who presents saying, "I worry about everything, whether the school budget will be approved, whether my daughter is safe driving, whether my husband's cholesterol is too high, whether I left the stove on." She reports this has been going on for years, at least since my 30s. She has chronic neck and shoulder tension, wakes at 3 a.m. with racing thoughts about the next day, snaps at her family over minor things, and feels exhausted by noon despite sleeping 7 hours. She says, "I know I worry too much, but I just can't stop." GAD 7 score, 17, severe. She meets criterion A, excessive worry about multiple domains greater than 6 months, criterion B, can't control it, and criterion C, muscle tension, sleep disturbance, irritability, fatigue equals 4 of 6 symptoms. Or PRN benzodiazepines rather than daily medication. Key differentiators. SAD fear is specific to social evaluation/scrutiny. Unlike GAD, worry about everything, SAD worry is focused on what will people think of me. Unlike agoraphobia, fear of situations where escape is difficult, SAD fear is about being judged. Patients often spend enormous mental energy on PRE situation anticipatory anxiety and post-situation rumination, replaying the interaction. Case example. Aisha, 24, is a graduate student who has been avoiding her thesis defense meetings. She says, "Every time I have to speak in front of my committee, my face turns bright red, my voice shakes, and I'm sure they think I'm incompetent." She avoids the department lounge because she's afraid of making small talk with professors. She eats lunch alone in her car to avoid the cafeteria. She has turned down 2 conference presentation opportunities. She reports these fears started in high school but have gotten unbearable in graduate school. She spends hours after every interaction replaying what she said, convinced she sounded stupid. She meets all criteria: marked fear of social scrutiny, A, fear of negative evaluation, B, social situations almost always provoke anxiety, C, avoidance, D, out of proportion, E, greater than 6 months, F, significant impairment, G. Diagnosis, social anxiety disorder. Treatment, start sertraline 25 mg, titrate to 50 to 200 mg. Refer for CBT with graduated exposure to social situations. For her thesis defense specifically, consider PRN propranolol 10 to 20 mg. Test dose first to reduce autonomic symptoms. 4. Specific phobia. The one thing fear. DSM-5 criteria, all must be met. Criterion A, marked fear or anxiety about a specific object or situation. For example, flying, heights, animals, receiving an injection, seeing blood. Criterion B, the phobic object or situation almost always provokes immediate fear or anxiety. Criterion C, the phobic object or situation is actively avoided or endured with intense fear or anxiety. Criterion D. The fear or anxiety is out of proportion to the actual danger posed by the specific object or situation and to the socio-cultural context. Criterion E. The fear, anxiety, or avoidance is persistent, typically lasting greater than or equal to 6 months. Criterion F. Clinically significant distress or impairment. Criterion G. Not better explained by another mental disorder. Subtypes specify: animal, dogs, spiders, insects, snakes; natural environment, heights, storms, water; blood injection injury, BII; needles, invasive medical procedures, blood situational; airplanes, elevators, enclosed places; other, choking, vomiting, loud sounds; costumed characters; board pearl, BII phobia. Is unique. Blood injection injury phobia is the only phobia and the only anxiety disorder that involves a vasovagal response. The initial sympathetic surge, tachycardia, hypertension, is followed by a parasympathetic rebound. Bradycardia, hypertension, leads to actual fainting. All other phobias cause sustained sympathetic activation, fight or flight without fainting. BII phobia also has the strongest familial/genetic component of all specific phobias. Treatment modification, the applied tension technique, patient tenses, large muscle groups during exposure to prevent the blood pressure drop. Key differentiators. The fear is circumscribed to one specific object/situation, unlike GAD, diffuse worry, panic disorder, unexpected attacks, or social anxiety, fear of scrutiny. Specific phobia is triggered by one identifiable stimulus. Patients may report no anxiety at all because they have rearranged their entire life to avoid the trigger. Case example. Tom, 38, is a construction foreman who has been offered a promotion to site supervisor, but the job requires him to inspect scaffolding on high-rise buildings. He says, "I can't go above the 3rd floor. My legs turn to jelly, my heart pounds, and I feel like I'm going to fall, even though I'm behind a railing." He has turned down the promotion. He avoids bridges, balconies, and glass elevators. He once had a panic attack on a Ferris wheel at his daughter's birthday party. He says, "I know it's irrational. The railing is solid, but I just can't do it." These fears have been present since childhood. He meets all criteria. Marked fear of heights. A. Heights almost always provoke fear. B. Active avoidance. C. Out of proportion. D. Persistent greater than 6 months. E. Significant impairment. Turning down a promotion. F. Diagnosis: specific phobia, natural environment type, heights. Treatment: first line is exposure therapy, graduated systematic exposure to heights. Start with photos to videos to low balconies to progressively higher floors. Medications are generally not first line for specific phobias. If needed for a specific unavoidable situation, e.g. a flight, PRN benzodiazepine can be considered. 5. Agoraphobia, the trapped feeling. DSM-5 criteria, all must be met. Therapy and / or CBT. Assess for comorbid depression and suicidality. D. The GAD-7 is not validated for clinical use check mark. Answer C. Severe anxiety. Initiate pharmacotherapy and / or CBT. Assess for comorbid depression and suicidality. The GAD-7 scoring is 0 to 4 equals minimal, 5 to 9 equals mild, 10 to 14 equals moderate, 15 to 21 equals severe. A score of 21 is the maximum and indicates severe anxiety requiring active treatment. A score of greater than or equal to 10 has 89% sensitivity and 82% specificity for GAD. However, the GAD-7 is a screening tool, not a diagnostic tool. A high score should prompt a clinical interview to confirm the diagnosis and determine the specific anxiety disorder, GAD, panic, social anxiety, etc. Critical next steps include assess for comorbid depression. Anxiety and depression co-occur in up to 60% of cases. Administer PHQ-9. Assess for suicidality. Rule out medical causes, hypothyroidism, pheochromocytoma, cardiac arrhythmias, substance use, and initiate treatment. For severe anxiety, pharmacotherapy. SSRI/SNRI, plus psychotherapy, CBT, is recommended over either alone. Question 7. The medical mimic. A 45-year-old woman presents with episodes of palpitations, sweating, tremor, and intense anxiety occurring several times per week. She also reports unintentional weight loss of 15 pounds, heat intolerance, and diarrhea. On exam, her heart rate is 110, she has a fine tremor, and her thyroid is diffusely enlarged. Before diagnosing an anxiety disorder, what must the PMHNP do? A. Start sertraline immediately. The symptoms are clearly anxiety. B. Order thyroid function tests. This presentation suggests hyperthyroidism. C. Start propranolol for the palpitations and tremor. D. Refer for CBT. Answer B. Order thyroid function tests. This presentation suggests hyperthyroidism. This is a critical board concept. Always rule out medical causes before diagnosing an anxiety disorder. The DSM-5 specifically requires that the disturbance is not attributable to the physiological effects of a substance or another medical condition. This patient has classic hyperthyroidism signs: weight loss, heat intolerance, tachycardia, tremor, diarrhea, and goiter that can perfectly mimic anxiety. Other medical conditions that mimic anxiety include pheochromocytoma, episodic hypertension, sweating, palpitations, cardiac arrhythmias, SVT, atrial fibrillation, hypoglycemia, pulmonary embolism, COPD, and medication/substance effects. Caffeine, stimulants, corticosteroids, thyroid hormone, decongestants, withdrawal from alcohol/benzodiazepines/opioids. The PMHNP should order TSH and free T4. If hyperthyroidism is confirmed, treating the thyroid condition will resolve the anxiety symptoms. Propranolol might actually be appropriate here, but for hyperthyroidism symptom management, not as an anxiolytic. Question 8. The benzodiazepine dilemma. A 55-year-old man with GAD has been on alprazolam 1 mg TID for 8 years, prescribed by his previous provider. He wants to continue it because it's the only thing that works. He also has a history of alcohol use disorder, in remission for 3 years, and mild COPD. His current GAD-7 score is 12 despite the alprazolam. What should the PMHNP do? A. Continue alprazolam. It's been working for 8 years. B. Increase alprazolam to 1.5 mg TID for better symptom control. C. Develop a plan to gradually taper alprazolam while initiating an SSRI/SNRI and CBTD. Abruptly discontinue alprazolam and start buspirone. Answer C. Develop a plan to gradually taper alprazolam while initiating an SSRI/SNRI and CBT. This patient has multiple red flags for continued benzodiazepine use: history of alcohol use disorder, cross-tolerance and addiction risk, COPD, benzodiazepines can cause respiratory depression, long-term use, 8 years, dependence is virtually certain, and still symptomatic. GAD-7 of 12 despite the medication, suggesting tolerance has developed. Benzodiazepines are not recommended as long-term monotherapy for anxiety disorders. The Lancet review states that benzodiazepines only act acutely, lead to relapse after discontinuation, and are associated with dependency, requiring strict monitoring. The correct approach is to start an SSRI or SNRI first, allow 4 to 6 weeks to reach therapeutic effect, initiate CBT simultaneously, and then begin a very gradual benzodiazepine taper, reduced by no more than 10 to 25% every 2 to 4 weeks. Never abruptly discontinue benzodiazepines after long-term use. DSM-5 criteria. All must be met. Criterion A. Marked fear or anxiety about greater than or equal to 2 of the following 5 situations: using public transportation, buses, trains, ships, planes, being in open spaces, parking lots, marketplaces, bridges, being in enclosed places, shops, theatres, cinemas, standing in line or being in a crowd, being outside of the home alone. Criterion B. The individual fears or avoids these situations because of thoughts that escape might be difficult or help might not be available in the event of developing panic-like symptoms or other incapacitating or embarrassing symptoms. For example, fear of falling in the elderly, fear of incontinence. Criterion C. The agoraphobic situations almost always provoke fear or anxiety. Criterion D. The agoraphobic situations are actively avoided, require the presence of a companion, or are endured with intense fear or anxiety. Criterion E. The fear or anxiety is out of proportion to the actual danger. Criterion F. The fear, anxiety, or avoidance is persistent, typically lasting greater than or equal to 6 months. Criterion G. Clinically significant distress or impairment. Criterion H. If another medical condition is present, the fear, anxiety, or avoidance is clearly excessive. Criterion 1. Not better explained by another mental disorder. Board Pearl. Agoraphobia is a separate diagnosis from panic disorder in DSM-5. A patient can have agoraphobia without panic disorder, and panic disorder without agoraphobia. They frequently co-occur, but they are independently diagnosed. The core fear in agoraphobia is about being trapped or unable to get help, not about the situation itself. Case example. Linda, 52, is a retired nurse who has progressively restricted her life over the past 2 years. She no longer drives on highways. What if I have a panic attack and can't pull over? Avoids grocery stores. The lines are too long. I feel trapped. Won't go to movie theatres. I need to sit on the aisle near the exit. And refuses to fly. I can't get off the plane if something happens. She will only leave the house if her husband drives and accompanies her. On days he works, she stays home entirely. She orders groceries online. She says, I feel like my world is shrinking. She meets criterion A, fears greater than or equal to 2 of 5 situations: public transportation, enclosed places, standing in line, being outside alone. Criterion B, fears escape will be difficult or help unavailable. And all remaining criteria: diagnosis, agoraphobia. If she also has recurrent unexpected panic attacks with persistent worry, she would receive both diagnoses, agoraphobia and panic disorder. Treatment: SSRI, sertraline or escitalopram, plus CBT with graduated in vivo exposure. Start with short trips to nearby stores with husband, to progressively longer trips, to trips alone, to highway driving, to enclosed spaces. 6. Separation anxiety disorder. Not just for kids. DSM-5 criteria. All must be met. Criterion A. Developmentally inappropriate and excessive fear or anxiety concerning separation from those to whom the individual is attached, as evidenced by greater than or equal to 3 of the following 8 symptoms. Recurrent excessive distress when anticipating or experiencing separation from home or attachment figures. Persistent, excessive worry about losing attachment figures or about possible harm to them, illness, injury, death. Persistent, excessive worry about an untoward event causing separation, getting lost, being kidnapped, having an accident. Persistent reluctance or refusal to go out, to school, to work, or elsewhere because of fear of separation. Persistent, excessive fear of or reluctance about being alone or without attachment figures. Persistent reluctance or refusal to sleep away from home or without being near an attachment figure. Repeated nightmares involving the theme of separation. Repeated complaints of physical symptoms. Headaches, stomach aches, nausea, vomiting. When separation occurs or is anticipated. Criterion B. The fear, anxiety, or avoidance is persistent, lasting at least 4 weeks in children/adolescents and typically greater than or equal to 6 months in adults. Criterion C. Clinically significant distress or impairment. Criterion D. Not better explained by another mental disorder. Board Pearl. Separation anxiety disorder is not just a childhood diagnosis. It can occur in adults and has a lifetime prevalence of 2 to 3%. Adult onset cases do exist. In adults, the attachment figure is typically a spouse/partner or parent, and the fear may manifest as excessive calling/texting, inability to travel for work, or refusal to sleep apart. Case example. Sophie, 7, has been refusing to go to school for 3 weeks. Every morning she cries, clings to her mother and says, "What if something bad happens to you while I'm at school?" She has nightmares about her mother dying in a car accident. She refuses to sleep in her own room and insists on sleeping in her parents' bed. She complains of stomach aches every school morning that resolve by mid-morning. Bupropion is wrong here. It can worsen anxiety. It's activating with norepinephrine dopamine reuptake inhibition. Buspirone is only effective for GAD, not depression, and adding it to an SSRI adds complexity without clear benefit. A benzodiazepine might be used short-term for acute anxiety but should not be the primary anxiety treatment. The Lancet review notes that comorbid depression is one factor that might prioritize pharmacotherapy over psychotherapy alone. Combined SSRI/SNRI plus CBT is the optimal approach for this severity level. Question 12. The panic attack versus panic disorder distinction. 3 patients present to the PMHNP reporting panic attacks. Which patient meets criteria for panic disorder? Patient A had 1 panic attack during a car accident 2 weeks ago. No further attacks. No worry about future attacks. Patient B has panic attacks only when she sees a spider. She avoids basements and garages. No attacks in other situations. Patient C has had 6 unexpected panic attacks over 3 months. She constantly worries about having another one, has started avoiding exercise, afraid it will trigger an attack, and checks her pulse multiple times daily. Answer: Patient C meets criteria for panic disorder. Patient A had a single panic attack in response to a traumatic event. Panic attacks can occur in the context of any disorder or even in healthy people during extreme stress. A single attack without persistent concern or behavioral change does not meet criteria for panic disorder. Patient B has panic attacks that are expected. They occur only in response to a specific phobic stimulus, spiders. This is specific phobia with panic attacks, not panic disorder. The DSM-5 specifies that panic disorder requires unexpected attacks. Patient C has recurrent unexpected attacks, 6 over 3 months, persistent concern about future attacks, constant worry, and significant maladaptive behavioral change, avoids exercise, checks pulse, meeting all 3 DSM-5 criteria for panic disorder. The key teaching point: panic attacks are a symptom that can occur across many disorders. Panic disorder is a specific diagnosis requiring unexpected attacks plus persistent worry or behavioral change for greater than or equal to 1 month. Question 13. The treatment duration. Question: a 40-year-old woman with social anxiety disorder has been on escitalopram 20 milligrams per day for 10 months. She is doing well. GAD-7 is 4. She's attending social events, and she recently gave a presentation at work. She asks, "Can I stop my medication now?" How should the PMHNP advise her? A. Yes, she's been on it long enough and is in remission. B. Continue for at least 12 months total, then consider a very gradual taper with close monitoring. C. She needs to stay on medication for life. D. Switch to buspirone for maintenance. Answer B. Continue for at least 12 months total, then consider a very gradual taper with close monitoring. The JAMA review states that for patients who respond to medication, the drug should be continued for at least 1 year to reduce relapse. Discontinuing antidepressants before 1 year leads to symptom relapse in up to 50% of patients. This patient has been on escitalopram for 10 months. She should continue for at least 2 more months to complete the minimum 12-month course. When discontinuation is attempted, it should be gradual, 1 dosage step per month, with close monitoring to distinguish between withdrawal symptoms and disorder relapse. If relapse occurs during or after taper, well-tolerated pharmacotherapy may be maintained indefinitely. Buspirone is not effective for social anxiety disorder. It only has evidence for GAD. The decision to taper should also consider the patient's history. If she has had multiple relapses, chronic symptoms, or severe impairment, longer-term or indefinite treatment may be warranted. Question 14. The interoceptive exposure concept. APMHNP is explaining CBT for panic disorder to a patient. The patient asks, "What is interoceptive exposure and why would I deliberately make myself feel panicky?" How should the PMHNP explain this? A. We'll have you avoid all situations that trigger panic. B. We'll deliberately induce panic-like physical sensations in a safe setting so your brain learns they are not dangerous. C. We'll use deep breathing to prevent panic attacks from ever happening. D. We'll use hypnosis to eliminate your fear response. Answer B. We'll deliberately induce panic-like physical sensations in a safe setting so your brain learns they are not dangerous. Interoceptive exposure is a core component of CBT for panic disorder. It involves systematically exposing the patient to the physical sensations they fear, palpitations, dizziness, shortness of breath, tingling, through safe exercises such as breathing through a straw, dyspnea, spinning in a chair, dizziness, running in place, tachycardia, or hyperventilating, tingling, lightheadedness. The JAMA Review. If she stays home, she won't go to birthday parties or sleepovers. Her mother reports, "She follows me from room to room at home. She won't even let me go to the bathroom alone." She meets criterion A with greater than or equal to 3 symptoms: excessive distress with separation, worry about harm to mother, refusal to go to school, refusal to sleep alone, nightmares about separation, physical symptoms. Duration greater than 4 weeks. Diagnosis: separation, anxiety disorder. Treatment: CBT with graduated exposure to separation, start with brief separations and progressively increase. Parent training / psychoeducation, and if severe, consider SSRI, fluoxetine or sertraline. Both have pediatric evidence. 7. Selective mutism. The silent speaker, DSM-5 criteria. All must be met. Criterion A. Consistent failure to speak in specific social situations in which there is an expectation for speaking. For example, at school, despite speaking in other situations, for example, at home. Criterion B. The disturbance interferes with educational or occupational achievement or with social communication. Criterion C. The duration is at least 1 month, not limited to the first month of school. Criterion D. The failure to speak is not attributable to a lack of knowledge of or comfort with the spoken language required in the social situation. Criterion E. Not better explained by a communication disorder and does not occur exclusively during the course of autism spectrum disorder, schizophrenia, or another psychotic disorder. Key points: selective mutism is rare. Prevalence approximately 0.7 to 0.8%, and is now classified as an anxiety disorder in DSM-5, reflecting the understanding that the failure to speak is driven by social anxiety, not oppositional behavior or a language deficit. These children typically speak normally at home but become frozen in school or other social settings. It is strongly associated with social anxiety disorder. Many children with selective mutism meet criteria for both. Case example. Ethan, 6, has been in first grade for 3 months. His teacher reports he has never spoken a single word in class. Not to the teacher, not to other children, not even during show and tell. He participates by nodding or pointing. At home, his parents say he is a chatterbox. He never stops talking. He speaks normally with his parents, his older sister, and his grandmother. He speaks to his best friend from preschool, but only when they are at Ethan's house, never at school. His parents confirm he has no speech or language delays. He speaks English fluently, the language of instruction. His teacher initially thought he was just shy, but after 3 months with no speech at school, she referred him for evaluation. He meets all criteria, fails to speak at school despite speaking at home. A. Interferes with educational achievement. B. Greater than 1 month beyond the first school month. C. Not due to language barrier. D. No communication disorder or ASD. E. Diagnosis: selective mutism. Treatment: CBT with graduated exposure. Start with whispering to one trusted person at school, to speaking to that person, to expanding to small groups, to speaking in class. Behavioral techniques like stimulus fading, having a parent present during school interactions, then gradually fading the parent out, and shaping, reinforcing any vocalization, then words, then sentences, are effective. SSRI, fluoxetine, can be considered for severe cases. Treatment: the master approach. First-line pharmacotherapy. SSR is and SNR is our first line for GAD, social anxiety disorder, and panic disorder. There is no clear superiority of any single SSRI or SNRI. Selection should be based on side effect profile, comorbidities, drug interactions, and patient preference. The key principle: start low, go slow. Anxiety patients are more sensitive to medication side effects than depression patients, and some side effects, jitteriness, palpitations, can mimic anxiety symptoms, causing patients to abandon treatment prematurely. GAD first-line options: escitalopram, sertraline, duloxetine, venlafaxine, XR paroxetine. A network meta-analysis found escitalopram, duloxetine, venlafaxine, and pregabalin to be most effective and well-tolerated for GAD. Buspirone is a second-line option. Only for GAD, it does not work for panic disorder or social anxiety disorder. It is not a controlled substance, has no dependence potential, and takes 2 to 4 weeks to work. Panic disorder first-line options: sertraline, escitalopram, paroxetine, venlafaxine, XR. Start at half the usual dose, for example sertraline 25 mg, not 50 mg, to avoid activation syndrome. Social anxiety disorder first-line options: paroxetine, sertraline, escitalopram, fluvoxamine, venlafaxine, XR. For performance-only subtype, PRN propranolol 10 to 40 mg or PRN benzodiazepine plus CBT. Specific phobia. Medications are generally not first line. Exposure therapy is the treatment of choice. PRN benzodiazepine only for unavoidable situations, for example, a necessary flight. What is OCD? Obsessive-compulsive disorder is a chronic, often debilitating condition characterized by obsessions, unwanted intrusive thoughts, images or urges that cause distress, and or compulsions, repetitive behaviors or mental acts performed to reduce that distress. The critical concept is that OCD is not about being neat or organized. It is about being trapped in a cycle of intrusive thoughts and ritualistic behaviors that the person cannot stop, despite recognizing they are excessive or irrational. OCD was moved out of the anxiety disorders chapter in DSM-5 and placed into its own category, obsessive, compulsive and related disorders, because research showed that while anxiety is common in OCD, it is a secondary feature, not the core problem. Not all individuals with OCD even experience anxiety. Many instead report interference, avoidance, or disgust. The OCD cycle, in one sentence: obsession triggers, distress leads to compulsion, temporarily relieves distress, to relief reinforces the compulsion to the cycle repeats, and worsens over time. Epidemiology. The numbers that matter. The lifetime prevalence of OCD in US adults is estimated at 1 to 3%, with cross-national data suggesting a combined lifetime prevalence of approximately 4.1% across diverse populations. The age of onset is bimodal. There are 2 peaks: late childhood/early adolescence, mean approximately 10 years, and early adulthood, mean approximately 21 years. More than 80% of cases begin by early adulthood, and onset after age 35 is unusual. In childhood onset, OCD, boys outnumber girls 2 to 3 to 1, but by adulthood the sex ratio equalizes to approximately 1 to 1. Men tend to have earlier onset than women, with nearly 25% of males developing symptoms before age 10. The mean time from symptom onset to first treatment is nearly 8 years. Patients often hide their symptoms out of shame or embarrassment. Without treatment, the course is usually chronic, with waxing and waning symptoms, and remission rates are only about 20%. OCD is associated with more disability-adjusted life years than multiple sclerosis and Parkinson's disease combined, and quality of life impairment is comparable to schizophrenia. Fewer than 40% of patients who come to clinical attention receive OCD-specific therapy, and fewer than 10% receive evidence-based treatment. DSM-5 Diagnostic Criteria. Spelled out.
Thanks for watching.
Criterion A,
Like and subscribe
presence
for
of
more
obsessions,
content.
compulsions, or both obsessions are defined by both of the following. 1. Recurrent and persistent thoughts, urges or images that are experienced at some time during the disturbance as intrusive and unwanted, and that in most individuals cause marked anxiety or distress. 2. The individual attempts to ignore or suppress such thoughts, urges or images, or to neutralize them with some other thought or action, that is, by performing a compulsion. Compulsions are defined by both of the following. 1. Repetitive behaviors, for example, hand-washing, ordering, checking, or mental acts, e.g., praying, counting, repeating words silently, that the individual feels driven to perform in response to an obsession or according to rules that must be applied rigidly. 2. The behaviors or mental acts are aimed at preventing or reducing anxiety or distress, or preventing some dreaded event or situation. However, these behaviors or mental acts are not connected in a realistic way with what they are designed to neutralize or prevent, or are clearly excessive. Board Pearl. Either obsessions or compulsions must be present, not necessarily both, to meet criterion A. However, most individuals, approximately 90%, have both. Board Pearl. Compulsions can be mental acts, counting, praying, repeating words silently, not just observable behaviors. Don't miss mental compulsions. They are invisible but just as impairing. Criterion B. Time-consuming or impairing. The obsessions or compulsions are time-consuming, for example, take more than 1 hour per day, or cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. The 1 hour rule. While not an absolute cutoff, spending greater than 1 hour per day on obsessions/compulsions is a commonly used clinical benchmark for time-consuming. Many patients spend 3 to 8+ hours per day. Criterion C. Not substance-related. The obsessive-compulsive symptoms are not attributable to the physiological effects of a substance, for example, a drug of abuse, a medication, or another medical condition. Criterion D. Not better explained by another disorder. The disturbance is not better explained by the symptoms of another mental disorder. The DSM-5 provides a long list of rule-outs: excessive worries, GAD, preoccupation with appearance, body dysmorphic disorder, difficulty discarding possessions, hoarding disorder, hair pulling, trichotillomania, skin picking, excoriation disorder, stereotypies, stereotypic movement disorder, ritualized eating, eating disorders, preoccupation with substances/gambling. Addictive disorders, preoccupation with illness, illness-anxiety disorder, sexual urges, paraphilic disorders, impulses, impulse control disorders, guilty ruminations, MDD, thought insertion or delusional preoccupations, schizophrenia spectrum, or repetitive patterns of behavior, autism spectrum disorder. DSM-5 specifiers, don't forget. These insight specifier, required. With good or fair insight, the individual recognizes that OCD beliefs are definitely or probably not true, or that they may or may not be true. Example, I know the stove is off, but I still have to check it 30 times. With poor insight, the individual thinks OCD beliefs are probably true. Example, the stove is probably still on. I really need to check again. With absent insight/delusional beliefs, the individual is completely convinced that OCD beliefs are true, less than or equal to 4% of patients. Example, the stove is on, I know it is, I have to go back. This can look like psychosis, but do not give an additional psychotic disorder diagnosis unless the delusional beliefs extend beyond OCD content. Board Pearl. Poorer insight equals worse long-term outcomes. Patients with absent insight may be more resistant to CBT because they don't recognize their thoughts as irrational and may benefit from antipsychotic augmentation. Tic-related specifier. Tic-related, The individual has a current or past history of a tic disorder. Up to 30% of individuals with OCD have a lifetime tic disorder, most commonly in males with childhood onset. This specifier matters because tic-related OCD may respond better to antipsychotic augmentation, NNT equals 2 for tic-related versus NNT equals 5 for non-tic-related. The 4 major symptom dimensions. CASH. OCD symptoms cluster into 4 major dimensions. Most patients have symptoms across multiple dimensions, and the dominant dimension can shift over time. C. Contamination obsessions plus cleaning/washing compulsions. This is the most recognizable OCD presentation. The patient fears germs, dirt, chemicals, bodily fluids, or environmental contaminants and responds with excessive hand washing, showering, cleaning, or avoidance of contaminated objects/places. Case. The hand washer. Rachel, 26, is a nurse who presents with raw, cracked, bleeding hands. She washes her hands 80 to 100 times per day, showers for 2 hours each morning, and has started wearing gloves at home. She says, "I know the germs are gone after the first wash, but I just don't feel clean. If I don't wash again, the anxiety is unbearable." She has been late to work repeatedly because of her morning shower ritual and was recently written up. She avoids touching doorknobs, elevator buttons, and handrails. Her YBOCS score is 28, moderate to severe. She has good insight. She knows her behavior is excessive but cannot stop. Diagnosis: OCD with good or fair insight, contamination/cleaning dimension. A. Arranging/symmetry obsessions plus ordering, counting, repeating compulsions. The patient feels intense discomfort when things are not just right, symmetrical, or in a specific order. Compulsions include arranging objects, counting, repeating actions a specific number of times, or doing things until they feel right. Case. The arranger. Marcus, 19, is a college student who takes 4 hours to get dressed each morning because he must put on and remove each article of clothing until it feels exactly right. He arranges his desk items in perfect symmetry before he can study, and if someone moves anything, he must start over. He reads each sentence in his textbook exactly 4 times. If he loses count, he starts the page over. He has fallen behind in all his classes. He says, "I know it doesn't make sense, but if I don't do it right, something terrible will happen. I just don't know what." YBOCS score, 32, moderate severe. Diagnosis: OCD with poor insight. He believes something terrible will happen. Symmetry/ordering/counting dimension. S. Sexual/religious/aggressive, forbidden/taboo thoughts. Obsessions plus related compulsions, mental rituals, reassurance seeking, checking, avoidance. These are the most distressing and most hidden OCD symptoms. Patients experience intrusive, unwanted thoughts about harming others, sexual acts they find repulsive, or blasphemous religious content. They are horrified by these thoughts, which is what makes them OCD, not dangerous impulses. Compulsions are often mental, praying, mentally reviewing, seeking reassurance, or avoidant, avoiding knives, children, religious settings. Case. The terrified mother. Sarah, 34, is a new mother who presents in tears. She reports intrusive images of stabbing her 3-month-old baby with a kitchen knife. She says, "I would never hurt my baby. I love her more than anything." But these thoughts won't stop, and I'm terrified I might lose control. She has removed all knives from the house, avoids being alone with the baby, and mentally reviews every interaction to make sure she didn't harm the baby. She asks her husband 20+ times daily, "Did I hurt the baby? Are you sure?" She has not slept because she stays awake watching the baby to make sure she doesn't do something in her sleep. YBOCS score, 34, moderate to severe. She has good insight. She knows she would never act on these thoughts. Diagnosis: OCD with good or fair insight. Forbidden/taboo thoughts. Aggressive dimension. Critical board. Pearl, intrusive thoughts of harm in OCD are ego-dystonic. The patient is horrified by them and does not want to act on them. This is the opposite of homicidal ideation, where the person may have intent or desire. OCD patients with harm obsessions are not dangerous. They are among the least likely people to act on violent thoughts because the thoughts cause them such extreme distress. Never hospitalize a patient for OCD harm obsessions alone. This reinforces the OCD cycle. H. Harm obsessions plus checking compulsions. The patient fears that they have caused or will cause harm through negligence, leaving the stove on, not locking the door, hitting someone with their car. Compulsions involve repeated checking, stove, locks, rearview mirror, emails, and reassurance seeking. Case. The checker. David, 42, is an accountant who cannot leave his house without checking the front door lock exactly 7 times, the stove knob 7 times, and every window 7 times. His morning routine takes 90 minutes. While driving to work, he is plagued by the thought, "Did I hit someone?" and drives back along his route 3 to 4 times checking for bodies. He rereads every email 15 times before sending to make sure he didn't accidentally write something offensive. He says, "I know I locked the door, I watched myself do it," but 30 seconds later, the doubt comes flooding back. YBOCS score, 26, moderate to severe. Diagnosis, OCD with good or fair insight. Harm/checking dimension. Assessment, the YBOCS, Yale-Brown Obsessive Compulsive Scale. The YBOCS is the gold standard clinician-rated measure for OCD severity. It consists of a symptom checklist to identify which obsessions and compulsions are present, and a 10-item severity scale, 5 items for obsessions, 5 for compulsions. Each item is scored 0 to 4, giving a total score range of 0 to 40. Severity levels, 0 to 13 equals mild, symptoms present but manageable, minimal interference with daily life. 14 to 25 equals moderate, symptoms cause noticeable distress and interference, but the person can still function, with difficulty. 26 to 34 equals moderate to severe, significant impairment in daily functioning, substantial time consumed by symptoms. 35 to 40 equals severe. Near constant obsessions/compulsions, severe impairment, may be unable to work or maintain relationships. Treatment response definition. A greater than or equal to 25 to 35% reduction in YBOCS score is considered a treatment response. A score of less than or equal to 12 suggests clinical wellness/remission. Self-report screening tools. The OCISV, Obsessive Compulsive Inventory short version, is a brief self-report screen. A score greater than or equal to 21 out of 72 suggests OCD. The Florida Obsessive Compulsive Inventory is another validated option. Differential diagnosis, OCD versus the lookalikes. OCD versus GAD. GAD worry is about real-life concerns, finances, health, relationships, and is experienced as excessive but normal worry. OCD obsessions are intrusive, unwanted, and often bizarre or ego-dystonic. Thoughts the person finds repulsive or senseless. GAD does not have compulsions. OCD versus specific phobia. Phobias involve fear of a specific external stimulus, spiders, heights. OCD involves fear of an internal thought or the consequences of not performing a ritual. A person with contamination. OCD doesn't just fear germs, they fear the thought that they might be contaminated and perform rituals to neutralize it. OCD versus OCPD. Obsessive-compulsive personality disorder. OCPD is a personality pattern of perfectionism, rigidity, and control that the person sees as desirable and ego-syntonic. I'm just thorough. OCD is ego-dystonic. The person recognizes the thoughts/behaviors as excessive and wants them to stop. OCPD does not involve true obsessions or compulsions. OCD versus psychosis. OCD with absent insight can look like psychosis, delusional beliefs. The key, OCD delusions are restricted to OCD themes: contamination, harm, symmetry. If delusional content extends beyond OCD themes, for example, the government is poisoning my food, consider a comorbid psychotic disorder. OCD versus eating disorders. Ritualized eating behaviors, Cutting food into exact pieces, eating in a specific order, can look like OCD compulsions. If the rituals are driven by body image/weight concerns, then eating disorder. If driven by contamination, fears, or just right feelings, leads to OCD. OCD versus autism spectrum disorder. ASD involves repetitive behaviors and insistence on sameness, but these are typically experienced as comforting and pleasurable, not distressing. OCD rituals are performed to reduce distress, not for enjoyment. The OCD-related disorders. Family OCD now lives in its own DSM-5 chapter alongside its relatives. Know these for boards. Body dysmorphic disorder, BDD. Preoccupation with perceived defects or flaws in physical appearance that are not observable or appear slight to others. The person performs repetitive behaviors, mirror checking, excessive grooming, skin picking, reassurance seeking, or mental acts, comparing appearance to others. Has insight specifier like OCD. Treatment, SSR, is plus CBT. Do not refer for cosmetic surgery. It does not resolve the preoccupation. Hoarding disorder. Persistent difficulty discarding possessions regardless of their actual value, due to a perceived need to save them and distress associated with discarding, results in accumulation that congests living areas and compromises their intended use. Now a separate diagnosis from OCD. Most hoarders do not meet OCD criteria, has insight specifier, responds poorly to SSR is alone, CBT with home-based exposure is the primary treatment. Trichotillomania, hair pulling disorder, recurrent pulling out of one's hair resulting in hair loss, with repeated attempts to decrease or stop. Not triggered by obsessions, often preceded by tension, boredom, or occurs automatically. Treatment, habit reversal training, HRT, N-acetylcysteine, NAC, has some evidence. Excoriation, skin picking disorder, recurrent picking of one's skin resulting in skin lesions, with repeated attempts to decrease or stop. Like trichotillomania, it is a body-focused repetitive behavior, not driven by obsessions. Treatment, HRT, SSR is NAC. Bored pearl. Trichotillomania and excoriation disorder are body-focused repetitive behaviors. They are not driven by obsessions or preoccupations, unlike OCD, BDD, and hoarding. They are preceded by emotional states like tension, anxiety, or boredom. Pharmacotherapy. The treatment ladder. Step 1, SSRIs. First line. SSRIs are the first-line pharmacotherapy for OCD. The FDA has approved 4 SSRIs specifically for OCD: fluoxetine, fluvoxamine, paroxetine, and sertraline. Citalopram and escitalopram are also effective but are not FDA approved for OCD off-label use. Meta-analyses show no meaningful differences in efficacy between individual SSRIs. Selection should be based on side effect profile, drug interactions, and patient factors. The big OCD dosing rule. OCD requires higher doses and longer trials than depression. OCD doses are typically at the high end or above typical antidepressant doses. The optimal dose is approximately 40 milligrams fluoxetine equivalent. An adequate trial requires 8 to 12 weeks at an adequate dose, compared to 4 to 6 weeks for depression. Up to 25% of patients who appear treatment refractory may still respond to SSRI monotherapy if continued up to 28 weeks. FDA-approved OCD doses. Fluoxetine. Start 20 milligrams per day to target 40 to 60 milligrams per day to max 80 milligrams per day. Fluvoxamine. Start 50 milligrams per day to target 200 milligrams per day to maximum 300 milligrams per day. Note potent CYP1A2 and CYP2C19 inhibitor. Watch for drug interactions with caffeine, theophylline, warfarin, benzodiazepines. Paroxetine. Start 20 milligrams per day to target 40 to 60 milligrams per day to maximum 60 milligrams per day. Sertraline. Start 50 milligrams per day to target 200 milligrams per day to maximum 200 milligrams per day. Off-label options: escitalopram 10 to 20 milligrams per day, citalopram 20 to 40 milligrams per day. Maximum 40 milligrams due to QT prolongation risk at higher doses. Response rates. Approximately 40 to 65% of patients respond to an SSRI or clomipramine, with a mean symptom improvement of 20 to 40%. The NNT for SSRIs versus placebo is 5, 95% CI 3 to 8. However, the probability of full remission with pharmacotherapy alone is low, only about 11% in one study. This is why combined treatment, SSRI plus ERP, is the gold standard. Duration of treatment. Continue medication for at least 1 to 2 years after achieving response. Relapse rates are 25 to 40% if medication is discontinued after 2 years, and up to 80% if discontinued sooner. Taper gradually when discontinuing. Step 2. Clomipramine, second line. Clomipramine is the only TCA with FDA approval for OCD. It is a potent serotonin reuptake inhibitor, more potent than SSR is, and has demonstrated efficacy equal to SSR is in meta-analyses. However, it is not first line because of its significant side effect burden. Anticholinergic effects, dry mouth, constipation, blurred vision, urinary retention, orthostatic hypertension, weight gain, sedation, sexual dysfunction, and, most importantly, risk of cardiac arrhythmias, cardiac toxicity, and seizures, especially at doses greater than 250 milligrams per day. Start low, 25 milligrams per day, titrate gradually to 100 to 250 milligrams per day. Requires ECG monitoring. Clomipramine is typically reserved for patients who fail greater than or equal to 2 SSRI trials. Step 3. Augmentation strategies, when SSRIs aren't enough. When a patient fails to achieve adequate response after 2 or more adequate SSRI trials, each 8 to 12 weeks at maximal tolerated dose, augmentation is the next step. Depression often develops secondary to the impairment caused by OCD. Treat both. SSR is address both conditions. Other anxiety disorders, GAD, social anxiety disorder, specific phobias, and panic disorder frequently co-occur. CBT can be adapted to address multiple anxiety conditions. Tic disorders. Up to 30% of OCD patients have a lifetime tic disorder, most commonly in males with childhood onset. Tic-related OCD may respond better to antipsychotic augmentation. ADHD, common comorbidity, especially in childhood onset OCD, can complicate treatment because stimulants may occasionally worsen OCD symptoms. Eating disorders. Ritualized eating behaviors may overlap with OCD compulsions. Careful differential diagnosis is needed. Psychotic disorders, OCD, and schizophrenia co-occur at higher rates than expected. Patients with comorbid psychosis often have poorer insight and worse outcomes. Special populations. Children and adolescents. CBT/ERP is first line for mild to moderate pediatric OCD. For moderate to severe cases, combined CBT plus SSRI is recommended. Fluoxetine, fluvoxamine, and sertraline are FDA approved for pediatric OCD. Approximately 40% of children with OCD may experience remission by early adulthood. Pregnancy, SSRIs, especially sertraline, are generally considered relatively safer in pregnancy. The risk of untreated OCD, including perinatal OCD with intrusive harm thoughts about the baby, must be weighed against medication risks. ERP/CBT is the preferred first-line treatment during pregnancy when feasible. Elderly. Start SSR is at lower doses, titrate slowly. Be cautious with clomipramine, anticholinergic burden, cardiac risk, fall risk. Monitor for drug interactions due to polypharmacy. The treatment algorithm, simple version, mild OCD, YBOCS 0 to 13, with good insight leads to ERP alone, CBT with exposure and response prevention. Moderate OCD, or YBOCS 14 to 25, leads to ERP plus SSRI. Combined treatment is optimal. Start SSRI, titrate to high dose, allow 8 to 12 weeks. Severe OCD, YBOCS 26 to 40. Poor insight or significant comorbidities leads to SSRI at maximal tolerated dose plus ERP. Consider specialist referral. Inadequate response to first SSRI, 8 to 12 weeks, leads to switch to a different SSRI, OR increased to very high dose. Consider clomipramine as alternative. Inadequate response to second SSRI leads to augment with aripiprazole or risperidone, especially if comorbid tics, or add CBT/ERP if not already receiving it. CBT augmentation is more effective than risperidone augmentation. Refractory to multiple trials implies consider glutamatergic augmentation, memantine, lamotrigine, TMS, or intensive residential treatment. DBS and cingulotomy are last resort options. The following figure from the JAMA review illustrates this stepwise treatment algorithm. Top 10 OCD board Pearls 1. OCD is not an anxiety disorder in DSM-5. It has its own chapter, Obsessive Compulsive and Related Disorders. Anxiety is secondary, not core. 2. OCD requires higher SSRI doses and longer trials than depression. Target maximal tolerated dose. Wait 8 to 12 weeks, not 4 to 6 weeks like depression. Some patients respond up to 28 weeks. 3. ERP is the most effective treatment for OCD, more effective than medication alone. 60 to 85% response rate, benefits last up to 5 years after treatment ends. 4. Full remission with medication alone is rare, approximately 11%. Combined SSRI plus ERP is the gold standard. 5. Harm obsessions are not dangerous. Intrusive thoughts of violence/harm in OCD are ego-dystonic. These patients are less likely to act on violent thoughts, not more. Do not hospitalize for OCD harm obsessions alone. 6. OCD versus OCPD. OCD is ego-dystonic. Patient wants it to stop. OCPD is ego-syntonic. Patient thinks their perfectionism is a virtue. They are completely different disorders. 7. The insight specifier matters clinically. Poor/absent insight equals worse outcomes. May need antipsychotic augmentation. May be less responsive to CBT. 8. Tic-related OCD responds better to antipsychotic augmentation, NNT of 2 versus NNT of 5 for non-tic-related OCD. 9. CBT beats risperidone for SSRI refractory OCD. A landmark study showed CBT augmentation was superior to risperidone augmentation in SSRI refractory patients. 10. Continue medication for 1 to 2 years after response. Relapse rates are 25 to 40% after 2 years of treatment, and up to 80% if stopped sooner. Master Mnemonics Cache, the 4 OCD symptom dimensions: contamination, arranging/symmetry, sexual/religious/aggressive, forbidden thoughts, harm/checking. OCD doses are OCD, outrageously cranked up doses. Remember that OCD requires higher SSRI doses than depression. 8 to 12 to 28. 8 weeks minimum trial, 12 weeks ideal trial, up to 28 weeks for late responders. 4 FDASSRIS.
Thanks for watching. Like and subscribe for more content.